outset, I like to thank Chairperson, Scientific Committee, Dr. Namrata, and whole AIS team for giving this IC. Though we have very few delegates over here, but even then it is very useful topic of confounding situation in coexisting eye diseases. Like cataract is a most common disease in the eye, and many people present for the first time with the cataract coexisting with the ocular disease for which they were not aware of himself. In such situation, physicians often found themselves in dilemma as to how to proceed further for the best possible outcome, visual outcome. So in my topic is confounding situation in management of coexisting cataract and glaucoma. Straightway, I am thankful to again all the co-instructor for sparing time for this IC. I have no financial disclosure. No textbook clearly explained about the management of coexisting cataract and glaucoma. And you must realize that this is very often encountered problem in day-to-day practice. And there is lots of combination and permutation exist insofar as the management concerned. And opinion of most of the ophthalmologists differ in the same clinical scenario. So there is no uniformity about how to go about the cases and when we encounter such cases. Managing and determining the visual potential in a case of a combined cataract and glaucoma is a challenging situation, and even hard to discern about how much glaucoma is contributing to reduced visual acuity and how much cataract is contributing to the reduced visual acuity. And even the greatest challenge is to when do cataract surgery alone, or followed by trap surgery, or trap surgery followed by cataract surgery, or both combined together. There is certain disadvantage of all the procedure. If you do the cataract surgery first, there may be earlier visual rehabilitation, but poor control of glaucoma because you are not taking care of the glaucoma part. It reduces the IOP, though difficult to achieve the target intraocular pressure for the particular patient. And if you do the trabeculotomy surgery in cases of first cataract surgery, there is a slightly poor results of trabeculotomy surgery. And again, if you are combining with the later on 2SS surgery, the risk of anesthesia is twice, cost and inconvenience to the patients. Similarly, if you do the glaucoma surgery first, you will have a better control of IOP, but delayed visual rehabilitation. Performing cataract surgery may compromise filtering surgery too. And again, the risk of anesthesia, twice, cost, inconvenience applies here too. If you combine both the surgery together, the potential advantage is patient convenience, definitely. Cost is lesser, easier for the patient, less stressful while awaiting the second surgery to the patient, less risk of anesthesia too. And you avoid potential post-operative intraocular spike, which is very important if you have a very compromised visual field. So it is better taken care with the combined surgery. And we will have a better long-term control of intraocular pressure. And then one of the best advantages is the very quick visual recovery. But the potential disadvantage is the more post-operative complications in the form of choroid detachment, shallow AC, even hyphema. Again, you will have Unde is not proper, then you will have aqueous misdirection also. This is inflammation is more in because you are combining both the surgeries. So it is definitely a disadvantage. And it is definitely a technically difficult surgery, so those who are well versed with the procedure may go for it. Though the visual recovery is early, but the surgical rehabilitation is longer because you are combining the 2-3 surgeries together. So before a factor to be considered in planning the management is age of the patient. Definitely age is the biggest target for while preparing managing the cataract with glaucoma surgery, because if a patient comes with the extremes of the age, definitely you would like to have a combined surgery. Intraocular pressure, again, if you are having maximum patient is taking maximum medical therapy and not controlled, definitely will have going to address both the disease in the same sitting. If you have a very advanced visual defect, amount of the cataract, these are all the contributory factor while planning the management. Surgeons, individual expertise, and the number of topical medicine being used, and target pressure, whether they are able to achieve the target pressure or not. You may encounter different clinical scenario. We'll have one patient comes with the controlled IOP on MMT, visiting for the first time in your clinic, and cataract amounting to the surgery. So you don't know what is the visual status, visual outcome, and if a patient particularly does not maintain the good record, and you are patient especially came to you for the for the opinion, and you want to do the cataract surgery. So plan would be different in those cases. And another clinical scenario is controlled intraocular pressure on maximum medical therapy, and it is your patient. You have been following patient since very long. You know what is the vision, how patient deteriorated, and it is not definitely you know that this is not due to the glaucoma part, which is contributing to the deterioration of vision. The plan would be different. You will definitely feel more comfortable in managing those cases. And I have encountered many patients, everybody would have been encountering that patient come for the cataract surgery for the first time and having high intraocular pressure, advanced CD ratio, and the amount, media opacity is like that, it is not possible to do visual field examination or even OCT, then plan would be definitely different in those cases. A patient is having uncontrolled intraocular pressure on maximum medical therapy plus cataract, advanced visual field defect, planning would be different. We would definitely like to have combined surgery in those cases. And patient with uncontrolled IOP on MMT plus cataract, mild visual field defect, definitely wouldn't like to do the combined surgery in those cases, because surgery taking care of cataract alone definitely going to lower the intraocular pressure. May put off 1 or 2 drugs from the patient installation. So I have made a flow chart, like glaucoma patient with the cataract. If you would done the history and physical examination, if patient is having decreased visual, affects daily activity and quality of life, mild glaucoma damage with good IOP control on 1 or 2 drugs, go for the cataract surgery. And you always do clear corneal phaco to save the conjunctiva for the future needed trabeculectomy. Glaucoma not controlled with medication. Glaucoma need MMT, advanced cupping and visual field defects, and glaucoma medicine patient is not able to tolerate. So in those cases, definitely it's combined with the cataract surgery and glaucoma surgery together. Depending upon your expertise, 1 or 2 site surgeries can be done, and antifibrotic agents should be used in those cases. Though 2 site surgery definitely lower on 1 or 2 millimeter of extra intraocular pressure lower, but it is not significantly significant while a study is quoted. If you have patient with acute or impending lens-related complication, having secondary glaucoma, example due to trauma, neovascular glaucoma, uveitic with high intraocular pressure, stage surgery would be preferable. Trap first, take care of the intraocular pressure, then do for the cataract surgery. Once your glaucoma is controlled, you can always better plan, and you can evaluate the patient's symptom and all. So this is a small video clip. This is a case of trabeculectomy. This is the case of neovascular glaucoma. I have injected 3 anti-VEGF, and now the new NVI is regressed and pressure is high, so there is a little amount of visual potential is there. So I decided to do the trap surgery in this case. While doing trap surgery alone, I always use a triangular flap in these cases. Not some may do rectangular flap too. So amount of pressure is higher. The patient was having pain and all, not due to the neovascularization iris, because of the intraocular pressure. So after taking care of the preoperatively intraocular pressure and all by mannitol and all, I did trabeculectomy surgery. Here I can just to show the osteum. Yes. Kelly's punch is utilized for making the incision and all. You can see after the surgery, suturing and all, you have a self-retaining air bubble. So this definitely is a marker of very good intraocular pressure, and in these cases. Another surgery is combined, just to show few clips. Again, I here use a rectangular flap, and I used the same site surgery. Many people don't find doing the surgery with the same site, superior site, because we have trained like that from the superior side in the previous year, so I could do both the site surgery. You do? Yeah. Did the phaco, uneventful phaco, now implantation. I didn't put pilocarpine to reduce the pupil size, just a stroking of the iris is sufficient to bring down the pupil. Even I didn't open up the side one scleral flap with the same flap. I am pulling out the, and after it is, yes, you can see the good PI and all. So this is the end of surgery. If you are utilizing two side surgery, always better to suture the corneal side if you are two side surgery to have a better post of AC formation. Thank you for your patience hearing. Now I invite Dr. Rajesh Sahai. Huh? Okay, you can ask the question, no problem. Usually trap fails, but in those cases you go for the AGV or implant is definitely better. बिल्कुल more inferior. So will worse with implant cost is very much high, so cheaper and advanced. Okay, thank you, Dr. Rajesh. Now Dr. Rajesh is delivering the lecture topic of coexisting cataract with diabetic macular edema. He is expert veterinary surgeon practicing in Lucknow. So go ahead, Dr. Rajesh, please. हाँ बीच में लगाना हटा दो.
Thank you, Nagendra sir, for giving me the opportunity to present one more IC with the same team. And this is our third year or fourth year? Fourth year of... So my topic is coexisting cataract and diabetic macular edema. Before going into the clinical details, let us know about the prevalence of diabetes, cataract, and that what is going to affect the whole population in recent times. So in the epidemiology of diabetic mellitus, it is according to International Diabetes Federation, type 1 and type 2 combined. There are 463 million diabetics globally. This is the data from 2019. And it is estimated to be 278 millions in 2030. So it's a huge number, and it will be 10.2% of the total population. And of them, between 20 to 79 years, 9.3% of global adult population will be suffering from diabetics. So it's a huge thing, and which will be, work manpower loss will be there. China, India, and United States remain the top diabetic nations. And what about diabetic retinopathy? eye is the organ where diabetes manifests first and is a reflection of systemic disease. Diabetic retinopathy is the leading cause of vision loss in the working age population. Among 463 million diabetics, 1/3 exhibit signs of diabetic retinopathy. The global prevalence of diabetic retinopathy is 22.27%, and diabetic macular edema is 6.117%. There's an Italian study which showed among 745 diabetic patients undergoing phaco, NPDR, PDR, and laser-treated retinopathy were present in 14.3, 1.7, and 7.5% respectively. And in the epidemiology of diabetic macular edema, this is the primary cause of vision loss in diabetic retinopathy. Among the 1/3 of diabetic retinopathy patients, 1/3 of them showed diabetic macular edema. OCT-based diagnosis criteria for a population-based study by Im et al., they showed that overall prevalence of diabetic macular edema was close to 5.5%. There was another study conducted in Italy, again, this was DICAT, Diabetes and Cataract 1, where they found 20.4% of all subjects undergoing cataract surgery were diabetics. The relative risk of diabetic macular edema was 1.8% in eyes without any retinopathy versus 6.6% in eyes with advanced retinopathy. The similar study with retrospective data analysis of 80,000 subjects in UK, they demonstrated worsening of macular edema following cataract surgery compared with normal eye. In continuation of that, the similar data and some more analysis, there was diabetic cataract 2 study. This is to characterize the increase of inflammatory mediators affecting retina with preoperative diabetic macular edema. This study showed that the presence of early diabetic macular edema prior to cataract surgery is associated with worsening of macular edema and vision loss after cataract surgery. These are very pertinent, this has answers very pertinent questions, how to counsel these patients and how to take up these patients for surgery with what, precautions and treatment. We all know that the pathophysiology of diabetes is hyperglycemia through various pathways, which triggers increased oxidative stress, inflammation, and vascular dysfunction. Oxidative stress and inflammation induce hypermodulation of growth factors and cytokines, leading to the breakdown of blood-retinal barrier. VEGF, angioproteins, tumor necrosis factor, interleukins, and matrix metalloproteinase, MMPs, are the key modulators. An imbalance between fluid entry, secondary to the breakdown of blood-retinal barrier, and dysfunctional fluid withdrawal of the RP and RMG results in an upset fluid electrolyte equilibrium and hence diabetic macular edema. So with these studies, there was another term came into being is the pseudophakic CME, that is PCME. Diabetic macular edema, we know that is associated with diabetics, and in patients with very mild diabetic retinopathy or no retinopathy had macular edema, but those were diagnosed diabetics. Those were known as PCME. So how to differentiate between the two? The normal DME presents with an underlying diabetic retinopathy, exudates, and macular edema. OCT shows features as microaneurysms, hard exudates, and a higher parafoveal outer nuclear layer to inner nuclear layer thickness ratio. Whereas the PCME presents with minimal diabetic retinopathy and the absence of exudates, OCT demonstrates a high central macular thickness to retinal volume ratio and intact hyperreflective outer retinal layer bands. Another study, a meta-analysis was done to find the, some agent which can help prevent the development of PCME in diabetic patients. So this identified the risk reduction during the peak period of 5 to 6 weeks following cataract surgery by concomitant use of NSAID drops. Use of anti-VEGFs had superior effect directly in DME and indirectly in vision. So what are the treatment options do we have for such macular edema? As I said, this meta-analysis showed us that if you concomitantly use NSAIDs, they have not mentioned which particular NSAID, but any NSAID for that matter will help in the topical form. Then one can use anti-VEGFs, which we are using intravitreal, steroids in any form and by any route, that is subtenons, intravitreal, suprachoroidal, all will help. Then we have lasers. Now with the advent of micropulse lasers, we can do some very close to the fovea lasers or subfoveal lasers we can do as well. And of course, the good diabetic control is the foremost requirement. As I said, mild macular grid photocoagulation is quite helpful, and sub-threshold diode micropulse laser photocoagulation also can be performed in such cases. The management of diabetic patients undergoing cataract surgery should be treated with topical non-steroidal anti-inflammatory agents to prevent PCME. And for patients with pre-existing DME, intravitreal therapies, both with anti-VEGF drugs and steroids, can be considered. So these are the options taken from that study, where what all these topical NSAIDs, topical corticosteroids, lasers, intravitreal corticosteroids, subtenon steroids, intravitreal anti-VEGF, all had their pros and cons, but all can be used for in particular situations. So the protocol that we follow in our, since there are many variables, there could be many permutations and combinations of treatment for such patients. We have developed a protocol looking into all the details of these studies. The intravitreal anti-VEGF at the end of cataract surgery is our normal practice in any diabetic patient who has diabetic retinopathy. And it has to be repeated after 1 month if needed. If we see that there is macular edema which has increased or is still there, we will do a repeat injection after 1 month. And laser photocoagulation following first anti-VEGF injection. And for refractory and recurrent cases, simultaneous anti-VEGF and suprachoroidal triamcinolone is our practice. In conclusion, India becoming a diabetic capital with ever-increasing cataracts coexisting with diabetes. Challenges in cataract surgery are good glycemic control before surgery, predictability of visual outcome, control of infection. These are the real challenges actually. And for that, we need to have a very good counseling of patients for future treatment, requirements for diabetic retinopathy will save us from embarrassment. Thanks for your patient hearing.
Thanks, Dr. Rajesh.
No, patients with diabetic retinopathy. See, you can have, since we have to have a protocol which has to be followed by everyone. So if it is a moderate or severe NPDR, even if there is no macular edema, we will give an anti-VEGF there at the end of the surgery.
Any preference for any particular anti-VEGF?
I'm an avid user of Avastin.
Again, thanks, Dr. Rajesh. Just one question.
Sir,
Patient
please.
अगर आता है,
हाँ.
you can see, you cannot examine the fundus properly because you just see few indirect exudates and all in the macula, and also you inject anti-VEGF.
Normally, if a patient has diabetic retinopathy, there is a protocol that we do an OCT before cataract surgery.
Yeah.
So OCT gives us small cyst or sometimes exudation or other changes in the macula. So that will guide us to the therapy. But by and large, this is the protocol which is followed. And we generally don't try to deviate from our fixed protocols. Otherwise, it will be very individualistic approach to the patient.
Thanks. Now I request Dr. Abhijit, who is a vitreoretinal surgeon practicing in Calcutta, and his topic is coexisting cataract and macular hold.
Present here with our teams. About the last presentation, I have some things to say about Dr. Rajesh's presentation. Usually we do OCT about for the diabetic patients, whether they are having previous macular edema or not, and if there is no edema, then we start NSAID eye drops 2 weeks before the cataract surgery, and we continue at least up to 6 weeks. And if there is edema, then we previous to the surgery we give the anti-VEGF. and we try to make it as minimum as possible, the macular edema, and then we do the surgery, because as you do the surgery, the edema will increase, and then we continue the anti-VEGF. Okay, thank you. So with my presentation is the cataract and macular hole. No financial interest involved. So challenge for both phaco and retina surgeon, because there may be pre-existing vitreomacular traction, subtle macular hole, post-phaco posterior vitreous detachment may worsen vitreomacular traction and create macular hole, and routine OCT before phaco, in fact now advocated by American Academy of Ophthalmology also, and maybe a better option to avoid embarrassment after surgery. So deciding factors are age of patient, grade of lens opacifications, ability to visualize retina and macula, and vitrectomy increases lens opacity progression, and gas tamponade further increases the risk of lens opacification. So this is the study which they are telling, after pars plana vitrectomy with gas tamponade, person with less than 50 years of age, cataract progression is not much significant, over few years even. But in persons over 50 years of age, the cataract progression is significant. So in elderly patient above 50 years with visually insignificant cataract also, they may go for phaco with simultaneous or prior to macular hole surgery. So that may help them to avoid another surgery. Causes of cataract post pars plana vitrectomy. There are 4 theories: the ionic composition of the infusion, temperature of the infusion, microscope light toxicity, increased posterior lens capsule permeability. And the subject of phaco prior to macular hole surgery, more complete vitreous removal possible if we operate for phaco before the macular hole, and larger gas bubbles for a bigger hole possible. Post pars plana vitrectomy phaco may be more difficult, in fact, due to the increased anterior depth, jonular weakness, and no anterivitreous support. And post-operative CME may reopen the previously closed hole also. Timing of phaco. In USA, they routinely do 2 to 3 weeks prior to macular hole surgery, but in all other parts of the world, combined phaco-vitrectomy is the preferred method. It decreases the number of surgeries, and minimum corneal edema should not be there, that we should see. That may create problem with ILM peel. Temporal section, hydration and paracentesis better be avoided, and it leads to quick rehabilitation. Here we can see one of the surgeries where, without assessing much about the lens opacity, it went for macular hole surgery, and you see the vision is not very clear with the view. So after putting BB dye and trying with the ILM, ultimately we went for the cataract surgery and put a lens. And put sutures, of course. And then you see the view becomes much clearer, and the normal way we could have peeled the ILM, for which we are struggling at the first instance. Which one? Yeah. It was the previously operated eye for the retinal detachment basically. আপনাদের পাওয়ার পয়েন্ট রেসপন্ড করছে না। Silicone hydrophobic oil, there will be fogging during surgery, contraindicated in silicone oil tamponade situations also. Mike? So actually hydrophilic IOL opacification risks are there. Multifocal lens absolutely no, because visualization may become very difficult in retinal surgeries. So there is one normal pseudophakic eye surgeries. You can see with the clear media how can it be a good surgery, because for macular hole surgery we need excellent visualization. That is the first and foremost thing. So for that, if we have to operate the cataract, if it is a insignificant also, then also we should go ahead. So here you can see that's a normal way which we do. And then we did a reverse flap technique here. We cut all around and trim it, and then with fluid exchange time we just put the soft tip cannula the way so that the flap gets inside the macular hole without touching the whole base. And that was the result. There is one other traumatic macular hole surgery, which you can see here. The papillomacular bundle area almost destroyed, and you can see the macular hole here, which we operate from the healthy retina. You can separate the ILM, and I put that ILM back to the whole base. And this is a Fennessy loop, just coaxing and cajoling the ILM over the hole, and then we do the fluid exchange. And this is the result. And the OCT, you can see it is closed, the V-separate closing. Thank you. These are the references. Thanks. Yeah, little bit of cataract, better to do the surgery first, because otherwise after particularly our elderly people, they will anyway will need the IOL surgery later on. Better we do. No, that we don't do.
How long do you, usually how many years do you see that cataract has developed after surgery?
The young patient I have seen even after 4 or 5 years also, they don't have much cataract progression. Like elderly patients, the more they are elder, the cataract progression is faster in fact. And we cannot tell with very firm convictions, but this fellow will have increased cataract and this fellow will not have.
But generally we counsel them like require cataract surgery sooner than later actually.
Otherwise, if you don't do the first surgery I showed you, there is already a cataract done, and then went for that macular hole and see the problem. Thank you.
Thanks, Dr. Abhijit, for your nice insight. And now I request Dr. Anita, are you prepared? Now, Dr. Anita is an additional professor at IIO Patna. I'm going to present his topic, in cataract coexisting with corneal opacity.
Yeah. ठीक है, इसी से करेंगे ना? Good morning, everyone, and thanks to Dr. Nagendra sir for giving me this opportunity to be part of this instruction course. I'll be talking on cataract coexisting with corneal opacity. Corneal opacity is a common comorbidity which we find very frequently in patients with cataract. The problem is that the presence of the corneal opacity makes visualization difficult, And along with that, these eyes with corneal opacity may be associated with small pupil, hard cataract. These might be one-eyed patients, which all adds to the problem and leads to higher risk for complications. So the management modalities is we can either do a plain cataract, we can do cataract surgery per se, or we can combine it with a keratoplasty. That is a triple procedure. So what our management modality will depend upon the location, the depth of the opacity, the expertise of the surgeon, the access to donor corneas, the visual status, and the requirement of the patient. Now, for example, this is a picture of a patient with a paracentral corneal opacity, nebular macular grade. And on full slit lamp illumination, we can see the edge of the pupillary margin. We can see the anterior capsule. It occupies less than half of the total pupillary area. So probably most of us would go in for a cataract surgery. This is one of our articles on long-term visual outcome in surgical management of cataract coexistent with corneal opacity in one-eyed patients. Basically, the take-home message was that if the corneal opacity is not obstructing the visual axis, or the patient cannot come for long-term follow-up, or the patient is one-eyed and he needs ambulatory vision. In these patients who are one-eyed, considering that keratoplasty can have long-term problems also and graft failure, etc., it might be wise in one-eyed patients to go ahead with the cataract surgery per se. The contraindications, of course, will be doing a combined procedure if there's a dense leukomatous corneal opacification in the visual axis, masking the anterior segment visibility. And we would avoid a surgery altogether if there is, of course, poor visual potential as identified by electrophysiological tests like a visual evoked potential where you can get a flat VP, or this presence of other ocular pathologies like optic atrophy, old RD, macular scar, advanced glaucoma. So it not be very useful to do these surgeries, but the decision to not operate must be individualized. Non-eyed patient with even projection of rays in one or two quadrants should be taken up for surgery, in my opinion. But surgery is only a part of the problem. Another problem is the intraocular lens power calculation, and this is a whole lecture in itself. But in short, the problem in these patients in power calculation would be measuring the axial length. Optical biometry is very difficult in terms, whenever there's a corneal opacity, so we might have to do ultrasound. And even then, it's difficult to get the measurements, but the patient can be told to keep a thumb ahead of him so that we can get proper ocular alignment. Along with that, the keratometry is difficult. We should try the manual. But in case the cornea is irregular and you're not getting good Myers, you can do a topography and get the keratometry readings from then. Then again, you can use a B-scan for the axial length. And the next comes the formula. Which formula to use? SRKT is used by most, but considering the fact that these corneal opacities can lead to thinning and changes in the ACD, it might be wise to go in for Holiday 2 or Haig's formula. Then another thing is which IOL you would like to put. Now, if it's a regular astigmatism, and maybe you can put because of the corneal opacity, you can go in for a toric, but you should be able to see the marking. And in irregular, I would avoid. So another point of decision making is whether to do a phacoemulsification or to do a manual small incision cataract surgery in these patients. So just a few points. Phaco is a closed chamber procedure, and there can be mechanical and thermal damage in the corneal endothelium. And many of these patients will be having adherent leukomas, and underneath the cornea, there might be a lesser amount of endothelium. Underneath the corneal opacity, there might be lesser amount of endothelial cells. Less amount of working space, plus the ultrasound vibration, increased phaco time and power can lead to more endothelium loss, turbulence of the irrigating fluid, chattering of the nuclear fragments can all lead to endothelial cell loss in an already compromised cornea. So in such cases, MCI, manual small incision cataract surgery, can be a safer option and may help in protecting the endothelium. Some modifications which might be needed in a manual small incision cataract surgery is to use viscoelastic on the cornea to improve the visualization, or you can use a contact lens filled with viscoelastic on the cornea. Capsular X-ray should be started in the quadrant opposite to the corneal opacity, preferably a forceps, And underneath the corneal opacity, it should be completed in one sweep. Judicious use of dispersive viscoelastic to protect the endothelium, and cohesive can be used to prevent the running out of the rhexis. In cases of small pupil pseudoexfoliation, stretching of the pupil, making sphincterotomy to help ease the surgical procedure can be done, or 2 to 3 relaxing incisions should be put on the visual part of the capsular rhexis to help in the prolapse of the nucleus. Apart from this, many people would use an endoilluminator which can be held at the limbus so that the oblique illumination gives a better view of the intraocular structures. Now this is the optics of how we see in a clear cornea and how we see in a scarred cornea. Coaxial illumination helps to illuminate the fundus, and then we are able to get a good fundal glow when the cornea is clear, as we can see in the first picture. And the presence of a corneal opacity can lead to scattering of light, poor illumination of the fundus, and hence difficulty in visualization of the eye during surgery. So what are the methods to improve the intraoperative visualization once we have decided which mode of surgery we are going to be doing? One is, of course, which we all use, a trip and blue dye, which helps to visualize the capsule, a transcolumn illumination, intracameral endoillumination, chandelier endoillumination, retroillumination, I think which about which Dr. Rajesh can tell us more later. These are some pictures. If you have a good microscope, you can get a good retroillumination and do surgery with that, or you can have an endoillumination probe in the vitreous cavity through a sclerotomy, or you can have a light pipe at the limbus to help see better in the anterior chamber. So this is an article by Titial et al. On dye-assisted small incision cataract surgery in eyes with cataract and coexisting corneal opacity, which says that with the microscope, in all these cases, whenever you are applying these, right, the microscope light has to be switched off. With the microscope light switched off and the endoilluminator placed externally at the limbus at an angle. This is an SICS that he is talking about. Better visualization was achieved, especially in critical steps like rhexis and cortical wash, and it can minimize complications and can be effective. So what are the modifications for phaco in corneal scars? Apart from the CCC rhexis tips that I just gave, the difference between SICS and here would be in the nucleus management. So we can do the phacoemulsification with a primary chop technique in cataracts of grade 2 or higher, and in cases of advanced cataract, you can do eccentric rate and forward chopping. The main thing is that the moment you chop, it should emulsify and create space for further maneuvering and rotation, etc. It will be best to do a bimanual irrigation aspiration, so for better accessibility under the areas of opacification. This is one of our articles on slit beam retroillumination assisted phacoemulsification for cataract with coexisting corneal opacity. This is something of which we have done a lot of cases, and this is the video. This was part of a presentation, so I'll try to. Okay, so you can see the first is under the microscope. The first picture is from the coaxial retroillumination. You cannot see much, but in the picture below where the slit beam is used, there's better visualization of the anterior capsule. So this voice is off. There's no voice. Anyway, so we can see this. I'm just trying to move it fast. So this is with the slit beam retroillumination. So you should keep it away from the area you are doing the rhexis. For example, if you want to start the rhexis from nasal, keep the beam temporal. And then you're able to get a better retro glow. Yeah. So this makes the surgery better, but of course it is dependent upon the retroillumination. You can see. And this gives better visualization than the coaxial retroillumination of the microscope. So the advantages is that it's hand-free, no added instruments, low cost. Drawbacks is that we are dependent upon the fundal glow. So in eyes with vitreous hemorrhage, it will not help. In poorly dilating pupil, it's not going to help. In advanced or wide cataracts, it's not going to help. So there are drawbacks, but if the posterior segment is fine, it's a good method to do. The other methods are there of intracameral illumination, that is with a 23G elimination probe. I don't have experience with this, but this can be tried out through the intracameral route. And it provides oblique illumination through a paracentesis, creating an enhanced three-dimensional effect, improved depth perception. Another advantage is that there is 360-degree visualization of the lens capsule structure, which is of great help in eyes with poor red reflex. And it provides, the endo-illuminator provides focus and stereoscopic illumination. And in contrast, this is in contrast with the problems of scattering, reflection, attenuation noted with a microscope light. So this is not my video, but I just thought that I'll just have this. This is with the endo-illuminator in the anterior chamber. See, so this is the kind of glow that you're getting. This is the kind of, this does help in the ease of different procedures. Especially you need this help in during the capsular access. This is with the endo-illuminator placed in the anterior chamber. Okay, now this is another, you can use endo-illuminator in the posterior chamber after doing a sclerotomy. And this is with the chandelier optics, which makes it hand-free. This provides a stationary and diffuse form of endo-illumination, and it enables bimanual surgery because one hand of the surgeon is not required to hold the endo-illuminator. This is another video. Again, this is from Cataract Coach. And here, the surgeon has used an endo-illuminator both in the anterior chamber and a chandelier light in the via sclerotomy. So there is added illumination both in the anterior chamber and from the retroillumination. So you can just see this was such a bad looking cornea, but the phaco has been done and the lens has been implanted by putting an endo-illuminator in the anterior chamber and in the posterior chamber. To conclude, the presence of corneal opacities can be challenging, but various studies have shown that phaco with IOL implantation causes significant improvement in the best corrected visual acuity in patients with cataract with corneal opacity. There should be an individual decision depending upon the type of corneal opacity, whether the patient is one-eyed, the expertise of the patient, whether there are donor corneas available or not. So all these factors should go into taking a decision whether phaco or SICS or a triple procedure is required. So it is also a safe and feasible method for patients who are poor candidates for transplantation, especially in one-eyed, and who are unable to comply with follow-up protocols. And phacoemulsification can also serve as an interim procedure to allow patients to become ambulatory while they wait for keratoplasty. Thank you.
Thanks, Dr. Anita, for a beautiful insight. 2-3 points I like to highlight: that always stain the capsule. Yes. Always, and always use forceps, and place your incision where when we were going to chop. There should be opposite side is always clear cornea.
Yes,
so
yes.
These
That is one point I've
and there is various. I think slit beam is not available in all the microscopes.
It is not, but in the higher ends only.
Yeah. Thanks. Any
questions?
question?
I have a question. Like in one of my cases, I tried to stain the capsule with the normal trypan blue, but it stained the cornea instead, and I had to postpone the surgery.
Maybe you kept the trypan for too long?
No, I just injected and everything, the cornea.
This usually.
No, but I had to postpone the surgery. I could not see anything through that.
You mean that the endothelium got stained?
Even there is always slight amount of blur if you are using the
slight amount of blurring is there.
If you are cataract, again, if you are cataract having corneal opacity, if you use trypan blue, may sometimes exaggerate the problem. So that hota hai, always hota hai. That is definitely. Yes. Yeah. Thanks, Dr. Anita. Now I request. I think next speaker, Dr. Indu, is not here due to some pressing situations. And can you go through the slides of Dr. Indu presentation? It is in my laptop.
Okay.
Or better do Dr. Sunil to present, then I will run through the slides. लाई हो ये नहीं चाहिए नहीं नहीं नहीं
ऑलरेडी पानी था यहाँ पर। मेरा वाला मत ले जाना। क्या हुआ? कुछ प्रॉब्लम हो रहा है?
With the coexisting diseases. My topic is cataract surgery in pterygium. I am Dr. Sunil. I am consultant director of Sanjeevani Eye Hospital at Patna. The presence of a pterygium interferes with the keratometry measurements related to calculate IOL. Pterygia flatten the cornea and induce astigmatism. The impact of a pterygium on the curvature of the cornea increases the longer it is. This results in inaccurate keratometry reading and some residual prescriptions left over after cataract surgery. The modalities of management are two. One is sequential cataract surgery, meaning thereby ki first pterygium and then cataract after a certain space of time, and there is a simultaneous and pterygium and cataract surgery. Simultaneous pterygium and cataract surgery is necessary only in patients who cannot easily access eye care facilities. A small asymptomatic pterygium that doesn't bother the patient could be left alone and may not affect refractory outcomes after the cataract surgery. Typically, lesions smaller than 3 mm don't tend to create irregularities of the cornea, but closely look at the corneal curvature before making this decision. If it seems to be affecting the corneal curvature, they should be then they should be removed for a good, stable, regular corneal curvature for cataract surgery. Patients with small pterygium at the limbus with regular Myers-on keratometry, regular corneal curvatures in topography, and a low or absent astigmatism can have cataract surgery before pterygium excision. Pterygium excision should not be done. Cataract surgery can go on. What led to this? There was a review of literature by Sharma B. Bajoria and et al., and which was said refractive outcomes of simultaneous pterygium and cataract surgery with fibrin glue. Then it showed that the steepening of the cornea after combined surgery results in myopia. Therefore, the IOL power should be selected appropriately. In the second literature also, like predictability of intraocular lens power calculation after simultaneous pterygium excision and cataract surgery, the conclusion was that simultaneous pterygium and cataract surgery was safe and effective, and the accuracy was moderately predictable. However, it should be noted that a significant myopic shift occurred post-operatively, possibly resulting from the steepening of the cornea after pterygium removal, especially when the size of pterygium was large. So sequentially, hence the need for sequential surgery. Some that look very thick or red might have an increased chance of causing more astigmatism than thin ones. But, however, if you look at the topography gives you the clear picture, and it doesn't show a large amount of astigmatism in topography, and it's not bothering the patient, it can be left. Should not be touched. This is large fleshy pterygium, and thus the regular astigmatism on pentacam. So the sequential surgery. Ensure adequate healing. Measurement after pterygium surgery after 4 and 6 weeks or 6 and 8 weeks after pterygium. Keratometry or topography should be repeated 6 weeks after pterygium excision, and preferably repeated 2 weeks later to determine whether the astigmatism is still changing or not. When astigmatism is not changing, then only you can go ahead with the cataract surgery. Now the choice of IOL choice of IOL depends primarily on the presence or absence of corneal astigmatism. In patients with significant corneal astigmatism or demonstrable higher order aberrations, which is HOAs, any IOL of one's preference can be used. Keratometry or topography should be repeated 6 weeks and 2 weeks later to determine whether the astigmatism is still changing. Phototherapy keratectomy can benefit patients with superficial corneal opacities, and PRK can help to regularize an irregular cornea. If the pterygium surgery leaves an irregular cornea, irregular astigmatism, these procedures can be had before the cataract surgery. Now the choice of IOL depends primarily on the presence of corneal astigmatism. Toric IOL. Patient who had large scarred pterygia may be left with significant irregular astigmatism. Irregular astigmatism, toric IOLs are not of much use, but contact lens may help. Toric IOLs can be used for regular corneal astigmatism of more than 1 or 1.5 diopters. Multifocal IOL are not a good option in patients with irregular astigmatism and higher level of HOAs, or any patient with higher degrees of corneal aberration. Now the surgical tips. Any surgery that involves extensive dissection of conjunctiva, like ECC IOL or SICS, should be best avoided in this patient because pterygium surgery always does with that conjunctiva, so scarring is more. So incision should be, meaning thereby that a phaco should be done with a small incision, very small. It is advisable to use a clear corneal cataract incision. Clear corneal, why? Because limbal stem cell deficiency has been implicated as a major cause of pterygium, and pterygium surgery may lead to further loss of stem cells if limbal incision is given. So a clear corneal cataract incision, and that also phaco. So review of literature, the conclusion is that post-operative refraction errors were positively correlated with the length of pterygium in the combined group. The unpredictability of these errors recommends sequential surgery in cases with concurrent pterygium and cataract. So pterygium excision tips in simultaneous surgery. Again, that article was that Sharma S.K. Bajoria, refractive outcomes of simultaneous pterygium and cataract surgery with fibrin glue. Conjunctival graft adhesion with fibrin glue is an ideal alternative to suturing in these combined cases because it shortens the operative time, it is easy to use, and is associated with less post-operative inflammation and discomfort. So for a conclusion, in all other cases, sequential surgery may be preferred. Pterygium surgery should be sequenced before cataract surgery when the pterygium is large enough to induce corneal curvature changes. This order will significantly reduce the incidence of refractive surprises after cataract surgery, which I have already said in the review of literature that it leads to myopic shift. So it leads to myopic shift, so IOL power calculation might give spring surprises. So small pterygium near the limbus, especially those that are atrophic, can be left alone and one can proceed with cataract surgery only. However, topography may detect subclinical extension of the pterygium into the center of the cornea. So that ends. Thanks, Rajesh and Anita. Any questions? Thanks.
I think, what do you practice in your clinical practice? I mean, do you do the pterygium surgery first, or do you do the cataract surgery and then do the pterygium surgery later, or you do it simultaneously?
First, now the advancement of pterygium surgery has come with that fibrin glue and the conjunctiva. First, what pterygium surgery we used to do was, in simplified form, it can be called a nochectomy. In the nochectomy era, so that was done with that, both the things that used to be done, but now we realized that simultaneous it should not be done. So now I have improvised myself that before I was doing together, now we don't do it. However, if the patient is from the rural background and we feel that that patient is not going to come after pterygium surgery, that patient might not come for the cataract, and it's patient with a rural background, little amount of this much myopic shift would not matter, and we'll go for the both. That's your wisdom and your judiciousness.
I think the house agrees with this, that usually what we do is that, very rightly said, if the patient really doesn't come for follow-up, then only you take this decision. Otherwise, doing a pterygium and then what extent of corneal de-roofing, de-surfacing you have done along with the pterygium. You have to use post-op medications if you do a concomitant cataract surgery. So you never think of doing a cataract surgery in combination with the pterygium, even if the pterygium is there and it is hindering the cataract surgery. It will be better than when you have removed the pterygium and proceeding ahead with the cataract surgery. So either you do the cataract surgery first, if the pterygium is not that big enough, or you do the cataract surgery, pterygium surgery earlier if it is large enough encroaching into the cornea. So this is what we are mostly following.
Most of the time, if the patient, most of the time, we just, if the pterygium is atrophic, it's not, we don't go for the topography and all. But normally, if it's if it's not interfering, we can go only for the cataract surgery.
See, in these cases, we rely upon the biometry findings of the other eye. We never follow or rely on the biometry of the affected eye, because it's bound to be erroneous.
Now the
No.
the more
If it is
practical
regular,
question is, the more practical question is, you don't do a pterygium before a cataract surgery, isn't it? You do a cataract surgery in whatever circumstance, if it is feasible, you will do a cataract surgery before pterygium surgery, right?
No. If it is sequential, pterygium surgery should be ideally done before. After 6 weeks, it is again reviewed, and then again after 8 weeks, if the astigmatism is not changing, then we go for the cataract surgery. But practically, what I said was that with the patients come with a rural background, they cannot come to you quite often. So what you do is, if pterygium is significant, if pterygium is not significant, we will take the IOL power of the next eye if it is pseudophagus, and then we'll do that same thing, cataract surgery only. But if pterygium is significant, we can do both the thing at one sitting in exceptional circumstances. Ideally, it should not be done.
Then if you do the same sitting, then how good going to, because you are aberrated the epithelium.
Exactly,
anyways,
administration of the
putting
steroid.
steroids.
See, what,
Chances
yes,
is
yeah.
technically
So,
Yes,
nahi,
so
this,
better to
these are the
Better
situations.
to avoid. But in that rural background, 85-year-old person comes. You go for the Ayushman person comes, and he is not going to come next time if you feel. That is in exceptional cases. Otherwise, normally you should do a sequential one.
Usually in these cases, what we try to practice is that this is a kind of a case where you have a mature senile cataract along with a progressive
And
pterygium.
rural background patient, aged
Progressive
patient.
pterygium with a mature cataract. Now, the patient requires something. It's not a rural background even, sir. The patient requires something to be done. It's a hyper-mature cataract along with a pterygium. You need to do. So, what you address is, you want to do the cataract. And secondly, you are thinking that whether we should do it in the same go pterygium or not. Now, what the question what Dr. Nagendra is trying to point out is that definitely putting post-operative steroids is an issue.
Yeah.
For the first week we follow it up. We try to put on a systemic regimen for 3-4 days and give non-steroidals and lubricants in that cataract surgery where the surface has been deprived, and after a week then you switch over to
It
the
should be avoided. It should be avoided.
steroids. That is the best way, because you have really debrided the cornea. And at that point of time, those background patients, even well-off, I'm not talking of those background patients, even well-off patients may land up with any kind of an infection, and that is really not desirable.
And pterygium has improved. The surgery with a graft and the fibrin glue, it has improved a lot. First pterygium, what we used to do, again I repeat it, that was the typical term was nochectomy.
Yeah.
You just catch it, you just nocho it, and that's all. You just
But
cauterize it.
even if you do the pterygium and you do a graft, that corneal portion is completely denuded.
True.
So for that, post-op regimen has to be for the first week. When you're doing it concomitant, you have
Very
to
tricky,
change
very
it.
tricky.
So
Yeah.
these becomes a little tricky.
Very tricky.
Apart from all these things, if you do suffered in one patient, right, the surgery was done, I thought, let me give him a bonus pterygium surgery. For 1.5 months, he was coming with watering and redness and grittiness and all kinds of very nicely done surgery. Ocular surface disorder, most unhappy patient.
Yeah.
This is all what happens in those, yeah. So in those cases, usually unless that pterygium is completely covering the cornea,
You should be avoided.
and if the patient is having a hypermature cataract with a pterygium,
Only cataract.
I prefer to do only the cataract first, let him be there for at least 2-3 months, and thereafter you do a planned pterygium surgery very nicely.
If the patient
and during
comes for follow-up.
and during the cataract surgery, you take all the K readings of the other eye, because this is really unpredictable.
Thanks, Dr. Sunil. We
Thank
had
you.
very
Thank you
long
very much.
discussion on cataract with pterygium. And
These, I think, this topic, I think, was very pertinent and very practical.
Yeah.
And I think no set guidelines, no fixed guidelines have been there. Everybody is getting experiences and sharing their experiences on the platform, and they are arriving at a consensus, I hope so. So that's why this IC and all the topics were very, very interesting.
We learn by committing mistakes. Like Anita said that
Practical, yeah.
practical था ये तो कहीं guideline नहीं है. You have to formulate or share your experiences and all.
we learn by committing mistakes. Like Anita said now that simultaneous surgery was done, and after 1.5 months, watering, redness, we all learn by mistakes.
Yeah.
We used to do it nowadays. We go for the sequential one now. It's in the rare cases only. Otherwise, you can leave pterygium as such. There is no need to touch if it's a rural background, little amount of astigmatism doesn't matter, slight amount of corneal astigmatism. Why? Why go for the pterygium? Only cataract.
Correct. And later on, if the patient comes and he earns for that surgery, you will do a planned pterygium surgery. That's.
Thanks, Dr. Sunil. Now, Dr. Indu is not here, so I request Dr. Anita to go through her slides. It is in there my laptop. So.
Coexisting amblyopia. Very interesting topics. Very interesting topics. Sir.
इसको just run through कर देंगे सर. मेरा देखा हुआ नहीं है बहुत ये slide.
और क्या?
नीचे वाला?
कुछ नहीं देता हमने तनी मनी हो गया हम
कनेक्ट भी नहीं है हुआ. मतलब फुल स्क्रीन नहीं आ रहा है. ये क्या है? ये क्या है सर? नहीं ये तो सेंड करना है. फिर नीचे है ही नहीं.
अरे वो तो 2 मिनट में
नहीं आ रहा. ओह ये
लेकिन
PDF
इसको हम लोग एक
PDF
पर्टिनेंट
बनाया
डिस्कशन
क्या?
में ले आए
PDF में है क्या? ये लगता है छोटा साइज का ये बना है ये. PPT का साइज छोटा है. फिर भी आना चाहिए उतना ही में.
क्या वजह अच्छा वंदे है
PDF है सर.
लेकिन लेट है बहुत 7 बजे हो गया
ऐसा हो रहा है.
हाँ सलावा से पूछिए ना
लाइन से तो चलेगा उसी को चलेगा. जो चलता है उसी को कर. For this IC, and this topic is on a very interesting topic: cataract coexisting with amblyopia. So amblyopia is a unilateral or a rarely bilateral decrease in visual acuity, which is caused by form vision deprivation and or abnormal binocular interaction, for which there is no identifiable pathology of the eye or visual. So this is the definition of mild, moderate, severe. I am not going to detail. We know what amblyopia is. So basically, the problem is twofolds. One is when is in infantile cataract, when we face cataracts in a child or in an infant, and then there is chance of amblyopia. And then in adults, when we might not be aware, but the patient has cataract, and we do the surgery, the vision doesn't improve. Probably the patient was amblyopic. So these are two scenarios, and obviously the infantile cataract needs more attention. So. So to prevent amblyopia in pediatric cataract, it's important that we identify the cataract, decide whether surgery has to be done. If it's like more than 3 mm, we are not able to see the fundus. No eye contact is there. There's nystagmus. All these patients will need to be operated, or there's squinting of the eye. So one decision will be whether we need to do the cataract surgery in a patient, or simply many of these patients are associated with cataract which is not exactly affecting the visual axis, the glow can be seen. And if we correct the refraction, many of these patients will be having astigmatic errors. If we correct the refraction in these patients, we don't have to go in for the cataract surgery in these infants. So a visually significant cataract is a 3 mm or a larger central opacity in the lens. And of course, infantile cataracts are most amblyogenic, so it's very important that we give our attention to these cataracts. And of course, we have to evaluate the cataract in children. There has to be a detailed examination, physical examination, ocular examination, laterality, whether it's bilateral or affecting only one eye, the morphology, the lens position, etc. The patient has to be examined under anesthesia, under GA, so that we are able to get the keratometry, the vertical diameters, and we're able to do a proper IOL power calculation. If we are planning to put an IOL, we need to go under GA to do a IOL power calculation. So the treatment modality would be to eliminate any obstacle to vision, such as cataract, correct any significant error, and force use of the poorer eye by limiting use of better eye by occlusion, penalization, active stimulation, pleoptics, etc. So we have to remove the cataract when the decision has been taken to do so. And then in a unilateral cataract, then we have to force the use of the poorer eye by these methods. So the management would be consider early surgery in young children with dense cataract. Of course, before that, we have to do the refraction to see whether vision improves with glasses. And then after the surgery, treat amblyopia. Or if we are not doing the surgery, then in cases of partial less dense cataract, then do patching or penalization. So how is pediatric cataract surgery different from adults? There's an elastic anterior and posterior capsule. If the visual outcome is it's not satisfactory, there can be amblyopia. Post-op inflammation is much more. 100% chances of PCO. Multiple surgeries might be needed, and of course long-term issue and management. Because the refraction of the child will be changing, there can be glaucoma later on also in these patients. So these things have to be taken into consideration. So the goal of the pediatric cataract surgery is a clear visual access and visual rehabilitation so that the patient doesn't develop amblyopia. Counseling is important, that long-term follow-up will be required. And if we are doing amblyopia therapy, again, follow-up and compliance is very important. So just to sum up, indications for early surgery in a child would be total cataract, unilateral cataract, asymmetric cataract, and associated features like nystagmus or strabismus. So this is basically how we are going to be doing a pediatric cataract surgery under GA mostly. And the next thing is the timing of the surgery, which is very important if you want to prevent amblyopia. So the decision to do the cataract surgery or to do the refraction, and then the timing of the surgery, and then how we are going to perform this surgery is all very important. So in case the patient is having unilateral dense cataract, which is more embryogenic, we have to do between 4 to 6 weeks. Not before that, because we don't want to end up with a glaucoma in a small eye. Bilateral congenital cataract, 6 to 8 weeks. These are less embryogenic. Okay, there is increased risk of glaucoma surgeries performed in first 4 weeks of life. And early surgery is required to prevent stimulus deprivation amblyopia. So the timing for surgery for infantile cataract has to involve balancing the risk of early surgery, that is the risk of GA, intraoperative risk, versus those of waiting, that which can end up in amblyopia. The surgical approach to these patients would be lensectomy, antrovitrectomy, management of the posterior capsule. Another thing is whether to put an IOL or no IOL. There are varied there's no particular agreement on whether to put IOL or no IOL, but usually what we do is we wait for the IOL to be put till the child is 2 years when maximum growth has taken place of the eye, and then we put the IOL. I'm sure many people differ on this, especially in cases of unilateral cataract. Unilateral cataract, you might want to put an IOL earlier because it's very difficult. You can't have a phakic glass in one and the child is not going to wear it. So that is a point of decision making. Myopic shift, of course, this is how a child's eye is different from an adult. It's not a miniature adult eye. And so we also have to take into account while putting an IOL that there's going to be a myopic shift with the increase in axial length in the child. So this is how we are going to target the post-op refraction. This chart according to age and what the target refraction will be, and accordingly we are going to place the IOL. Posterior capsular management is very important because 100% they'll be opacifying, so we have to do a primary posterior capsular access and an antrovitrectomy to keep a clear visual access. This cannot be overemphasized. How in a child it's very important to have a clear visual access. Okay, these are the post-operative complications, glaucoma, etc. Inflammation, lot of inflammation can be seen in these children. And then, of course, after the cataract surgery, first was the decision to do the cataract surgery, then the timing of the cataract surgery, then the method of the cataract surgery, and then, of course, after the cataract surgery has been done, the management of amblyopia, which would be first prevention and early detection of the cataract, so that the amblyopia doesn't become dense, and then after the surgery is done to do treatment of the amblyopia. So the amblyopia therapy can be by patching, penalization, optic correction, and pleoptics. And of course, the follow-up is very important, because every follow-up we have to see the visual acuity, the fixation, and then we might have to change the refraction with the length of the eyeball changing. So prognosis would depend on whether the cataract was unilateral or bilateral, the density of the cataract, the degree of visual impairment, and the compliance of the patient. So managing amblyopia in a child with cataract requires a lot of effort and a lot of thought into different process of it. Amblyopia in adults is comparatively easier to manage. Only thing I think is the identification before surgery that this patient might be amblyopic, and accordingly we counsel the patient that he might not gain the desired refraction, the desired vision after the surgery. So how do we come to this conclusion that this patient, adult patient with cataract, is having amblyopia? We do biometry, and if there is difference in axial length between two eyes, consider possibility of amblyopia. Anisometric amblyopia is common with difference of more than plus 2D hyperopia and 4D myopia between two eyes. So apart from noticing, okay, that maybe this patient doesn't have this much of cataract but he's having this much of vision, you find a discrepancy, look at the other eye, see if there is any difference in the axial length, think that maybe there's amblyopia, counsel, and then proceed with the surgery like we do normally. So pre-op counseling is must. One thing would be to operate the non-amblyopic eye first, so that the patient is happy with the vision, and then go in for the amblyopic eye. To conclude, the important consideration for surgery here would, of course, be slit lamp examination, increase in axial length in growing eyes, we are talking about the pediatric eye, oil implantation, whether to put an IOL or whether to leave it aphakic, then of course the IOL power calculation, how much we are going to target, be prepared for marked inflammation, 100% chances of after cataract, so in your surgery, do the primary postural capsulexis, the antravitrectomy to keep the vision axis clean, and of course the management of amblyopia post-surgery. And I've noticed that sometimes when you tell the optometrist to take the vision in the child after you have done the cataract surgery, they don't take it properly, and I think this vision should be taken by the surgeon himself. Because I've ended up with a patient amblyopia, because all the time the optometrist was saying the vision is 6'9", the vision is 6'9". To conclude, surgery alone for infantile cataract will not be successful without appropriate and timely optical rehabilitation and close monitoring for strabismus, glaucoma, and amblyopia. And in adults undergoing cataract surgery, biometry of both eyes to detect possibility of anisometric amblyopia, and preoperative counseling is advisable. Thank you.
Thanks, Dr. for readily agreeable for presentation of Dr. Indu Pandey. Thanks. This ends our IC.
Do you invite questions? Do you invite questions? You mean to say that in adult, like you have to take the biometry of both the eyes just for the prognosticating it, no? Prognosticating that, so that you should not have any surprises, the patient should not have any surprises. And the child, what were you saying? Again, repeat that thing. What precautions should you take before operating in a child? Possibility.
That is important. That will take
Under GA.
Yes, in the smaller children, yes, it is very difficult to get the readings without GA. So you have had, but we don't have, so 100 kilometers, of course, there are there.
Sedate करके भी
Sedate करके.
अच्छा, मैं normal optical biometer में. तो after sedation, there is not many GA after Finargan पिलाके कर लीजिए, ठीक है.
लेकिन हम इसको बहुत ट्राई करते हैं, because I hate to put the child through GA two times.
वही तो under GA, that is main concern.
The GA is the main concern. ये बहुत मुश्किल होता है वैसे करना.
That is good. That is a good option. Axial length under GA, acha. But then biometry under GA, how is it possible? नहीं, you just please explain ना.
रिफ्रैक्शन भी कर लो डायरेक्टली अंडर जीए तुरंत रिफ्रैक्शन भी कर लो
नहीं, under GA, how can you do biometry?
हैंडहेल्ड करके कर
Handheld वाला.
हैंडहेल्ड से और एक्सियल लेंथ निकालना है।
नॉर्मल थियोटोमीटर आता है ऐसे वाला, वो भी डिटैच हो जाता है, you can use it as a handheld also. That can also, normal thiyotometer you can
But
detach.
what Rajesh said na, is a more easy option. No sedation to GA only one point of time, and then you can do that. Put the patient on that biometer and just forcibly open the eyes with a speculum. You can for a. You have to put GA twice. You have to put GA twice now. You have to put GA twice. हाँ काम कर रहा है, काम कर रहा है.
So everybody is invited to the valedictory ceremony in Hall 7.
Before going to, we have photographs of all this.
Photograph all. Please come for photograph, including Varuni.